inviting me to mid-talk webinar series, Pain Management Webinar. I'll be talking about challenges in the management of pain in patients with addictive disorders. Disclosures. I have no disclosures related to the content of this presentation. Outline of the presentation. I'll be discussing the relation between pain and addiction, the management of pain in patients who are currently opioid dependent, the management of pain in patients on methadone, the management of pain in patients on buprenorphine, and the management of pain in recovering addicts. There is a strong association between pain and psychopathology in general, particularly depressive disorders and anxiety disorders, somatoform disorders, substance use disorders, as well as personality disorders. Regarding the relation between pain and addiction, in retrospective analyses, nearly all chronic pain patients who developed problems with opioid use had a prior history of addiction. However, prospective longitudinal studies in well-characterized patient populations are still lacking. Addiction and pain are interrelated, with each condition influencing the treatment of the other. Patients with addictive disorders have special clinical considerations and are at increased risk of receiving inadequate pain management. There are three broad categories of clinical considerations specific to these patient populations. There are issues related to addiction itself, such as abuse of opioid, altered pain perception, and adherence to pain drug therapy, as well as its monitoring. Also, there are issues regarding drug interactions between illicit substances and prescribed pain medications. Last but not least, there are issues related to comorbidities of patients with addiction. Example, psychiatric disorders or physical concerns related to the addiction that should influence medication selection. The interface between addiction and pain. Addictive disease appears to augment the experience of pain, and evidence suggests that people with addictions have decreased pain tolerance. The presence of both conditions can result in reorganization of baseline perceptual pathways in the brain that results in increased pain perception. Physiologic states common in patients with addiction can affect nociceptive input, processing, and/or modulation. Chronic use of addictive drugs may affect the processing of pain stimuli through sympathetic stimulation, hypothalamic pituitary adrenal axis dysregulation, as well as opioid tolerance. Intoxication and withdrawal both activate the sympathetic nervous system, which augment the patient's pain perception. This activation of the sympathetic nervous system also results in increased muscle tension, irritability, and anxiety, further contributing to discomfort. Withdrawal is associated with negative affective states caused by dopamine depletion in the brain that exacerbates discomfort in patients with addiction. Personality traits of the patients with addiction, such as external locus of control and a tendency to perceive circumstances as worse than they are and to expect the worst to happen, have been associated with poorer outcomes in patients with pain. In addition, these patients often experience interpersonal conflicts and loss of social support that are detrimental to adequate pain management. The use of alcohol is also correlated with pain, so there are important considerations regarding the use of alcohol, as it can increase usually in response to distress, including chronic pain. Problems with alcohol intoxication include carelessness with other medications and accidents, alcohol-related physical comorbidities, which also can be painful, interaction between alcohol and other drugs, increased risk of respiratory depression, particularly when alcohol is abused with opioids, as well as benzodiazepines. Use of alcohol correlates with depression and anxiety, compounding distress from pain. Alcohol reduces quality of sleep, compounding distress from pain. Clinical dilemmas in the management of pain in patients with addictive disorders. There are a lot of dilemmas. Of course, we always ask ourselves, should we prescribe opioid analgesics for patients with addiction? There are two major dilemmas: regulatory issues, because physician can get in trouble with the law, as well as clinical issues, because we keep asking ourselves, is it a good clinical practice? Regarding the regulatory issues, the use of opioid to treat opioid addiction is limited to legally approved opioid treatment programs. Physicians may prescribe opioids to addicts for pain as long as the charts clearly documents that opioids are being used to treat pain and not for addiction. Regarding physicians' attitude towards addicted patients with pain, physicians generally has an attitude of distrust towards patients with pain, particularly the patient with history of substance use. This barrier leads to less than optimal pain treatment. If the patient is undertreated and consequently exhibits signs of pseudo-addiction, assessment and management of pain become even more difficult. It is critical for all parties to openly acknowledge the history of substance abuse. The first step in forming a plan to address the patient's pain is to obtain accurate knowledge of the patient's current and past substance use. There is also the dilemma of undertreated pain versus overprescribing. The contributing factors for this dilemma are the lack of knowledge among prescribers about current pain management guidelines, risk management practices, and research in pain medicine, as well as lack of knowledge among prescribers about addiction, dependence, and misuse. We have to know the difference between physical dependence and addiction. Physical dependence is an expected response to chronic administration of many classes of drugs, including opioids. Physical dependence is a separate and distinct issue from compulsive, consequential drug-taking behaviors of addiction. Physical dependence is a state of adaptation manifested by a drug plus specific withdrawal syndrome that can be produced by abrupt cessation, rapid dose reduction, decreased blood concentration, and/or administration of an antagonist. Tolerance is a state of adaptation in which exposure to a drug induces changes that result in a decrease of the drug's effect over time. Addiction is a psychiatric condition associated with neurobiological changes and behavioral manifestations. People with addiction often have both tolerance and physical dependence, but not all patients who are tolerant or physically dependent are addicted. What is pseudo-addiction? Pseudo-addiction is a term used to describe aberrant drug-seeking behaviors in patients with undertreated pain. In pseudo-addiction, the behaviors resolve with adequate pain relief. Behaviors in pseudo-addiction resemble addiction that occur only when the pain is undertreated. And these behaviors include watching the clock for the pain medication in hospital, seeking of drugs or drug-seeking behavior, and doctor shopping. Asking for specific medications by name. We'll find patients asking for specifically for oxycodone, for example. Hoarding of medications. Unsanctioned escalation in dose. These behaviors resolve when the pain is adequately treated. What about pain control in the addicted patient? What about patient needs? There are a number of reasons why individuals who are drug dependent may have greater than expected needs regarding pain relief. This includes the fact that virtually all forms of addiction are associated with sleep disturbance, and this is a well-established exacerbating factor in chronic pain. Also, depression and anxiety are common features in addiction, and these have an important influence on pain experience. Drug users are more likely to suffer from accidental as well as non-accidental injuries and medical complications related to their drug use. This places them at high risk from physical problems that may require analgesia. In general, pain management goals of therapy include minimizing the physiological adverse effects of unrelieved pain, avoid adverse effects of therapy, maximize non-pharmacological treatment approaches, improve quality of life, and educate about self-care of pain. Regarding pain management goals of therapy for patients with addictive disorders, it includes, above the previously mentioned goals, to prevent withdrawal, to provide effective analgesia, to prevent relapse to addiction, to provide effective treatment of opioid addiction, that's to say maintenance opioid therapy, and to provide treatment of psychiatric disorders that are comorbid such as anxiety. Regarding pain management goals of therapy for patients with opioid addiction have an additional set of goals because of the complexity of their clinical circumstances. It is important for any patient with chronic pain and the clinician to understand that the complete absence of pain may not be a realistic goal, but a decrease of pain to facilitate increased functioning is likely to be attainable. Patients should set personal goals for therapy based on their activities of daily living. For example, to participate in family events, to maintain a job. And patients whose only goal is to be pain-free may consider treatment as a failure if this state is not achieved, and therefore be more likely to self-medicate. Self-medications can lead to full-blown relapse of addiction and the consequent lack of adherence to the global treatment plan. Therapeutic success can be compromised by many errors on the part of the patients and practitioners, as setting unrealistic goals and giving insufficient time for an intervention to work. A practitioner can err by imposing an overly tight restrictions on opioids, resulting in inadequate pain relief that in turn lead to drug-seeking behavior by the patient, which leads to further restriction in pain drugs. This vicious circle can prevent therapeutic success. The multidisciplinary team dealing with pain in addiction is formed of the pain specialists, addiction psychiatrists, specialist nurse, as well as clinical psychologists. Consultation with others involved in patient's care should underpin management. It's particularly important that substance misuse team and the patient's primary care team are kept informed of the progress with pain management. This is normal good clinical practice, but also supports safe pain management by generating accurate information regarding a patient's current prescribed treatment and minimizes the risk of a patient seeking medications from more than one source. An informed consent is very important, including discussion of the risks and benefits of the pain medications, as well as having a written agreement. In the written agreement, the patient agrees to have one prescriber, one pharmacy to safeguard medications, no replacement of lost or stolen medications, no illegal substance use, no diversion by selling or sharing, urine toxicology testing. Patient evaluation include complete history and physical examination of the patient with detailed pain history, physical examination, prior treatment history, indications for opioid analgesia under accepted medical standards of care, history of substance abuse. It's important to discuss the patient's use of alcohol. As we mentioned before, this also has specific relevance to the experience of and management of pain. A psychiatric history, communicate with prior clinicians to obtain prior records. Also, we have to do periodic review of analgesic response, any aberrant behaviors, signs of addiction or diversion, functional status. The patients on effective analgesia should have improved function, while if the patient is having addictive disorders, they will get worse. And we have always to evaluate, do the benefits of opioid analgesics continue to outweigh any risks or not? Signs of addiction in pain patients include aberrant behaviors as lost or stolen prescriptions, escalating doses and early renewals, obtaining medications from other sources, use of pain medications for psychic effects as to relieve anxiety, increase energy, or for euphoria, unwillingness to try non-opioid medications, deterioration in functioning, injection or snorting of medicines, crushing controlled release preparations, resistance to changes in treatment regardless of adverse effects, refusal to comply with random urine drug screens or referral to pain management specialists, current abuse of alcohol or illicit drugs, and use of multiple pharmacies. Diversion of prescribed controlled medications for other than legitimate medical uses poses a threat to the individual and society. Prescribers have a responsibility to minimize the potential for abuse and diversion of controlled substances, but efforts to stop diversion should not interfere with the legitimate use of opioids for pain management. General considerations when managing chronic pain in opioid-addicted patients. Pain symptoms must be properly evaluated, including relevant investigations and taking note of potential contributors to the patient's current experience of pain. If non-pharmacological interventions are known to have utility for pain conditions described, they should be offered to the patient with a clear explanation of why such interventions are likely to help. Similarly, non-opioid medications should be used where supported by evidence, again with clear discussion of rationale for any drug used. Patients already tolerant to a long-term illicit or prescription opioids taken for addiction will derive little analgesic effects from their regular dose. If the patient needs opioid analgesia, these drugs will have to be prescribed in addition to any existing prescribed regimen. For those using illicit opioids, prescribed doses must include replacement of the patient's usual opioid consumption. The therapeutic regimen should be selected with the risk of aberrant drug-related behaviors in mind. For example, short-acting opioids, as pethidine, are widely acknowledged to have greater abuse potential than long-acting or sustained-release preparation. Also, non-sustained release tablets can be more easily crushed and injected. A patient may refuse to consider a transition to sustained release preparation. The prescriber must communicate clearly with the patient about setting reasonable expectations or goals for therapy and about the necessity to frequently assess the progress towards these goals. This must include a regular review of the prescription. The process of building trust between clinician and the patient should include a candid discussion of acceptable and unacceptable behavior. The results of such a discussion should be written down and given to the patient. Beware of various potential presentations of drug-seeking behavior. Refer the patient to or seek advice from a pain specialist or substance misuse specialist at an early stage where appropriate. Pain management is underpinned by good communication with the patient and reassurance that pain will be managed optimally. Medications should be part of a wider plan to support self-management. Mental health diagnoses and emotional difficulties need to be identified and managed. Physical rehabilitations, exercise, and psychological treatments are essential to support chronic pain management. Close collaboration with drug services and the patient's GP is mandatory, including confirmation of substance misuse. Regimens should avoid prescription of multiple opioids. Opioids are poorly effective in chronic pain. Opioid prescribing in the setting of current opioid misuse or abuse. Depending on the severity of misuse or abuse, the options of counseling the patient and implementing specific interventions may avail themselves. For example, if the patient is frequently running short of tablets, the GP ought to increase the frequency with which the patient collects tablets from a single pharmacy and to see them more frequently for prescription. GPs must be clear about indicating which behaviors are unacceptable. These behaviors should have been outlined and discussed prior to a trial of opioid for chronic pain. Continued drug misuse or abuse, despite repeated interventions, may in some cases indicate the need to discontinue prescribing of potentially abusable drugs, and in other cases provide the impetus for termination of the GP-patient relationship. The GP should be prepared to respond in these ways and should understand both the options for non-drug therapies and the approach of termination without abandonment. That's to say, appropriate referral to a practitioner with experience in drug treatment. A useful way of avoiding abandonment may involve transferring the patient to opioid substitution program, whether methadone or buprenorphine. The program has the advantage of providing supervised daily dosing of methadone or buprenorphine in a manner that helps to reduce risks associated with opioid misuse or abuse, while still providing a degree of opioid pain relief. For patients on methadone, we can split the dose and give it in 12-hourly regimen, and for patients on buprenorphine, we can split the dose and give it in 8 to 12-hourly regimen. In case of methadone, if an opioid analgesic is appropriate, a non-methadone opioid may be co-prescribed in patients who are maintained on methadone. It is not necessary to rationalize the patient's entire opioid requirement to one drug. Regarding buprenorphine, the partial agonist action of this drug means that it should not be prescribed as an analgesic to patients receiving full agonist, whether in the form of methadone or patients still taking heroin, because in this condition, withdrawal may be precipitated. Similarly, patients taking high-dose buprenorphine as substitution therapy may be relatively refractory to opioids prescribed for analgesia. It was found that conversion of high-dose opioids to buprenorphine can lead to much more improvement in pain after this conversion, as shown in the slide. Buprenorphine might be a good option as frontline analgesic because it's effective for cancer pain, for neuropathic pain, for broad array of pain phenotypes. It produces less constipation and has no effect on sphincter of Oddi. It has sealing effect on respiratory depression, less cognitive impairment, not immunosuppressive like fentanyl or morphine, doesn't adversely affect the hypothalamo-pituitary adrenal axis or cause hypogonadism, does not cause QT prolongation, effective in elderly, safe in renal failure and for those on dialysis. Withdrawal is milder and it has lower abuse liability than full agonists. Naltrexone is a long-acting opioid antagonist, and patients receiving it as therapy for addiction are likely to be refractory to opioid analgesia. In addition, administration of opioid antagonists lead to upregulation of opioid receptors with a consequent period of opioid sensitivity. When opioid therapy is introduced after cessation of naltrexone, careful monitoring will be required. In order to maintain an appropriate level of support for patient, discontinuation of naltrexone should be discussed with their addiction treatment team. In case where there is an urgent need for opioid analgesia, this requires continuous infusion to displace naltrexone from the opioid receptor. However, the patient will require close continuous monitoring, as once the naltrexone has been displaced, there is risk of opioid toxicity from the agonist agent. Chronic pain management for patients who are already in recovery from addiction. Prolonged substance misuse leads to permanent change in the neural reward circuitry. This gives rise to potential of reactivation of a substance misuse problem if drugs of misuse need to be prescribed for pain control. This results in considerable anxiety for the patient, who may underreport his or her symptoms, and also concerns for healthcare professionals who may undermedicate pain for the fear of inducing relapse. Patients and clinicians need to understand that drug exposure is only one component of relapse. Careful plan for pain management with involvement of appropriate expertise can facilitate optimal treatment. The management of acute pain in these patients needs to include a clear plan for cessation of therapy and a plan for appropriate support following discharge from hospital. Risk of relapse may occur both with use of opioids and under treatment of pain. Use of non-opioid interventions where possible is, of course, preferred. Careful explanation of risks and benefits of the proposed treatment plan should be discussed with the patient. And anxiety should be assessed and managed, if necessary, with medications. Patients may have strongly held beliefs regarding opioid therapy, and these should be respected. In case of opioid prescribing for patients in recovery from addiction, we have to agree the treatment plan with the patient and other healthcare providers, agree the outcomes of treatment, consider a short trial of opioids, like 2 weeks, assess risks to determine frequency of review. For long-term prescribing, use sustained release preparations. Don't exceed 120 mg per day of morphine equivalent. If opioids don't work, stop them, of course. Take-home messages. There is increased prevalence and perception of pain in addicted patients. Proper treatment of pain improves outcomes, so they should not be denied proper treatment of their pain. They are more likely to use illicit opioids and have more drug-seeking behavior, so watch for any signs of these behaviors. When using opioids, follow the harm-benefit paradigm. Continue if benefit outweighs harm, and discontinue if harm outweighs. Perform frequent monitoring, reassessment, and documentation. Thank you.